the three goals which I'll be covering here, I'll recap what Dr. Minal has mentioned. I'll mention about the glycemic goals and the treatment algorithm. So I'll ask you to read this scenario and give me a quick answer. A 35-year-old man from Ahmedabad complains of tiredness. I want interaction here. I want people to be awake. On examination, BMI of 25.5 kg per meter square. Checks his blood glucose, which is around 130, which is 6.1 millimole per liter. My question to you, is this gentleman having diabetes, yes or no? If it's yes, please raise your hands. Okay. No, raise your hands. Brilliant. So if you have no osmotic symptoms, which tiredness I'll not consider as an osmotic symptom, and the blood glucose was high only on one occasion, this can't be termed as diabetes, right? So all credit to people who have given the right answer, that you need to check it again. In presence of osmotic symptoms, I would have labeled this gentleman as having diabetes, right? So you need two abnormal results from different tests or the same test on two different time points. Very simple. As I said, I'm just recapping what Dr. Minal has already covered. Easy? Let's move on. As I said, the complexity of things will change as we'll move on. So I'm sharing the criteria from different guidelines. If you see in the middle, Americans are very aggressive about labeling people as pre-diabetes. In Europe, we are probably less, aggressive, I'll say, in that sense. And my question is, once we label people as pre-diabetes, are we medicalizing something? But that's for another debate. Clinical scenario 2. As I said, I've got 6 or 7 clinical scenarios. If I see people dozing off, I'll ask them questions, right? I'll pinpoint them. Go through the clinical scenario. Tell me, what do you think? Do you think it's type 1 or type 2? Very simple. So I'm getting some answers here. And as I said, I want interaction here. You can read n number of things online at the moment. I'm not here to preach you anything. I want you to reflect on things, think, and give me answers. So people are saying it's type 1. Raise hands if you think it's type 1. Raise hands if you think it's monogenic or type 2. Okay. So my question is totally different here. Which of the following investigation will be useful to establish the diagnosis? So I had given you somebody with normal BMI, relatively young. My definition of old is somebody who's older than me. So bar has been changing for last 30 years. So how many will go for C-peptide measurement? Okay. How many will do genetics for monogenic diabetes? Anyone who will do islet cell antibodies? All right, okay. So the correct answer, based on the algorithm given by the Americans, again, most of my talk is based on ADA standard practice criteria, which were published in Diabetes Care about a month ago. So I'll not be able to, we'll not be able to externally have external validation of these criteria, because this is based on white Caucasian population. So to apply it to Asian group is inappropriate in my view. But overall, if you go through it, if you're suspecting type 1, you'll do islet cell antibodies. They can be negative in 5%. If you're suspecting monogenic diabetes, you probably will do C-peptide. But if you're suspecting type 2, there is no point in doing C-peptide in first 3 to 5 years post-diagnosis. That was the crux, the message I wanted to convey to you. As I said, it's not a theoretical exercise. C-peptide, as we all know, we can do a random measurement within 5 hours of food. We do ask for blood glucose monitoring along with it. Because if somebody is having hypoglycemia, C-peptide may be spuriously low. So it's a good practice to do a glucose level along with C-peptide measurement within 5 hours of taking food. Ideally speaking, you should be measuring it after 3 years. In fact, I'll say over 5 years. I've got a patient under my follow-up with PGA type 2 Schmidt syndrome. She was having C-peptide positive till around 6 or 7 years post-diagnosis. So, but overall the consensus is that levels which are less than 200 picomole per liter suggest insulin deficiency, right? So far we have covered the diagnostic part. We moved into a bit of classification part of it. Let's go into the third clinical scenario now. Anyone wants to give an answer after reading it? 23-year-old, raised fasting glucose, strong family history of diabetes, BMI normal, and HbA1c 5.6. Dr. Minal has already covered it. It's a more than one fasting glucose which are high in somebody with normal BMI. So I'm not talking about type 1 or type 2. What do you think? Monogenic with? Yeah, so monogenic with glucokinase mutation. So persistent hyperglycemia with no chances of developing complication. It's likely to be monogenic. And I've often asked myself, which group of patients I need to refer for monogenic testing? 98% of time people are going to be type 2. It's that 2%. And is it relevant for me to do, such money expensive thing of testing for the genes? Is there any need for it? The only point which I can reinforce to you, if you've got HNF 1 alpha or 4 alpha, people are very sensitive to sulfonylureas. And occasionally in clinical practice, you can take people off insulin if they've been mislabeled as type 1. So that's the only relevance. Neonatal diabetes has been touched upon, so I'll not cover it. So there is something sorry. It only goes one way. I need to ask them to, oh goodness. Is it any way for me to go back?
Yes, sir. There's a button that takes the slides reverse also.
Right, let's see.
In your slide changes, sir.
Right. So there is no point in being so IT naive from my point of view. Okay, that's fine, I've managed it. So for diagnostic criteria for monogenic diabetes, I'm sharing it with you. Oh God. Right. Remember, if there is strong family history, it's running in 3 generations, and I've got a running joke on it. Some people come to my clinic and say, diabetes runs in my family, doc. And I say to them that, okay, because nobody runs in your family, diabetes runs in your family. So anyways, I say it under a muted kind of breath, I don't say it loudly. So these are the diagnostic criteria for monogenic. Okay, let's move on to the real game now. I've got around 32 minutes. This, you need to pay attention from this point onwards. Happy with it? What do you think is the diagnosis here? Pre-diabetes. Everybody agrees? Say loud yes if you agree with it. Say no say everyone is wrong. Yep, it is pre-diabetes. So, and what do you think is the most appropriate management approach here? Like, what about metformins and GLP-1s? Is there any evidence for it? And how do we decide the cutoff for diabetes versus pre-diabetes. Why we call 7 as diabetes and under 7. Do the things change drastically at 7, which are not there on 6.9? We've given a fasting criteria of, let's say, 126 milligram or 7 millimole. What does change under 7 and what does change? I'm asking, if somebody is learned enough. There were some DM people some clinicians. Have you ever asked why 126 milligram or 7 is the cutoff? Why not 124? The complications are more once the sugar level. Which complication? Retinopathy was the first one. So the moment the glucose is high, retinopathy. And retinal examination is excellent. That's the only place you can see the vasculature clearly. So, and what do we do with pre-diabetes? What's your choices? Physical activity, diet, and the third pillar is sleep. And if you go by the ADA diabetes recent standard practice criteria, they say we need to ask our patients to step, sweat, strengthen, right? So if you increase your step count by 500, your CVD risk reduces by 2 to 8%. If you start to do 5 to 6 minutes of brisk exercise, it increases your life expectancy by around 4 years. So increase step, standing if you're sitting for a long time. Increased level of physical activity. The guidelines say around 150 minutes of moderate exercise over 5 days in a week spread over, or 75 minutes of high intensity things. How many of you are doing it? 150 per minute, per week. Brilliant. You need to lead by example. You can't just say it. If you have to practice what you preach. Sleep. How many hours optimum? 6 to 8. Longer than that, not good. Owls do worse than larks. So early risers do better. And it's the quality of sleep which is important. So 4 pillars again: sleep, step, strength. And strength exercises are very important because muscles are the ones which have GLUT4 receptors. If there is increased muscle tone, I tell my patients it will eat out your glucose, so it lowers insulin resistance. If there is one single slide which is the most important one for you to spread awareness, it is this one. And if you think about it, pre-diabetes prevalence in UK at the moment is around 1 in 3 adult individuals. I don't know how much prevalent it is in other parts, but it's a huge challenge, huge burden for us. Let's move to the next real game now. We've covered diagnosis, classification very briefly. We talked about pre-diabetes. Next one. I'm just going through a story here. I'm not doing anything. 32 I'll call very young. When you reach age of 53, you think 30, I was a kid. On metformin, complaining of increased thirst and daytime somnolence, BMI 35.5, blood pressure 148 by 88 millimeter of mercury, and has background diabetes retinopathy. So if I ask you, and I'll show you these parameters, have this story in mind, because I'm going to ask you something on which you can reflect. HbA1c 55, which is 7.2%, trigs high, LDL cholesterol 3 millimole per liter. So my questions to you, and you've got a pen and pencil in front of you. I'll revise it. We've got half an hour tomorrow for clinical scenarios again. What will be your blood glucose target for this gentleman? What will be your target HbA1c? I'm not going to ask you loudly to answer it. I see a southpaw sitting on the front, which is nice, southpaw left-hander. supposed to be very intelligent. I'm an exception. Glucose target, HbA1c target, blood pressure target, LDL cholesterol target, and body weight target. I'm not going to give any answer, and we'll go through this journey as we move on. Happy with it? So, second question. Are you okay with, have you written down your goals, Patrick? All good? So, what will be your preferred therapeutic option? Because we are clinicians. Anyone can mention about lifestyle, and most of my relatives when I visit India ask me about diabetes medication, and I ask them to walk, run, cut down their diet. They said, you're coming from UK, you need to give us good medication. You're writing metformin again and a statin, so you're wasting our time. Anyways, what will be your preferred therapeutic option for this gentleman? To improve glycemic control, lower the blood pressure, lower LDL cholesterol and triglyceride. Have you written it up? I'm not asking for any answers at the moment. So when you make a decision in treating an individual, your goal of care should be around the person you are treating. You need to know about what they'll prefer, the comorbidities, how much can they afford. It's no point in having n number of knowledge and having gone through every evidence base if your approach is not patient centric. And management plan needs to be smart, in which it has to be specific, measurable, achievable, realistic, and time limited. I've taken the slides from American Diabetes Association current practice guidelines published in Diabetes Care Jan 2025 last month. Thanks to Dr. Banshi and Dr. Amit, I had to revise them at a short notice. So glycemic goals, if I individualize them, ideally speaking, and this is again a personal opinion, if person is fit, well, I'll go for a normal control if I'm using medications which are not leading to hypoglycemia. And obviously cost of therapy comes in play here. Pre-meal 4.4 to 7.2, post-prandial peak less than 10, and if somebody can afford in type 2 and using CGM, target range over 70%. And if they are on hypoglycemia inducing medication, they should not be having hypoglycemia, right? So simple, nothing major. What about body weight? What is an ideal body weight? Do we think body mass index is a good measure of it? Yes or no? Body mass index, how many think is the best way to measure your visceral adiposity? So what is the alternative? Waist circumference? Are we doing it in clinical practice? How we do it? Why don't we rely on it? And some of the time when we label patients as normal body mass index, they may be sarcopenic. So if you are losing muscle mass, your body mass index may be low. If you've got good muscle mass, your BMI may be spuriously high also. So BMI between 25 to 30 is misleading. In fact, in Asian population, cutoff is 23.5, right? We carry more visceral adipose tissue. 3 to 7% from weight loss from the baseline will improve glycemic control. Greater than 10% body weight loss, usually at the beginning of the disease, will improve overall control and has disease modifying effect. I graduated in 95 and I remember rheumatoid arthritis management like a pyramid. You start with the basics, chloroquine and blah, 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 and then you go into more stronger immunotherapies and all. They were not even available then. The only thing which was available was methotrexate. I think the approach we use for diabetes needs to change, like rheumatoid arthritis was changed. You don't want complications to set in before you act. The reversal of pyramid for rheumatoid arthritis started in late 90s with availability of immunomodulators. Similarly, in type 2, we need to think totally out of box. You need to have a proactive approach and try your best not to let the complication set in. Moment they have got complication, probably you have lost a part of it, right? So I'm reinforcing the word disease modifying agents. I'll say if somebody is able to lose weight by whatever modality, that will lead to disease modification, and that's what our aim is. Okay, I didn't give you any answer because we'll discuss that part even tomorrow, and this was more for self-reflection. I'll cover this topic again in the next talk. So, sixth clinical scenario. Read it. 54, type 2 for 12 years. Second line, most of us are using at the moment is SGLT2 inhibitors. I normally don't use trade names, but in here I had to write a clinical scenario, so I had to write name of a medication, atorvastatin and losartan. Is complaining of generalized aches and pains. On examination, BMI is 30.5 kg per meter square. Happy with the clinical scenario? See her blood test results. There is deranged liver function, right? So my first clinical scenario was on pre-diabetes, then I did early diabetes. In here, there is a lady with deranged liver function. So my question to you, which will be the most optimum therapy for management of a glycemic control, and that too in context of deranged liver function? Do you want to write it down? She's already on a metformin and a SGLT2 inhibitor. Glycemic control is still not optimized. Which medication you think will be the safer option with these liver function? Second question, which is clinically relevant here, what is the possibility of deranged liver function? Are you giving it a label of what used to be NASH, now called MAFLD, metabolic dysfunction associated liver disease? Are statins safe in, if the LFT are deranged? Will you stop the statin? What will be your target LDL cholesterol? And I'll reinforce when I'm doing the CVD talk the importance of LDLs and all. How many will stop the statins here? Raise your hands with the liver function I had given. Okay. Anyone else? How many will continue with the statins? Good. We'll continue with it. Till the ALT and AST are less than 3 times the upper range of normal, you continue with it. When I'm seeing somebody with diabetes, I'm not looking at glucose, I'm looking at their CVD risk. 2/3 of the patients with type 2 over age of 55 die of a cardiovascular event. So CVD risk reduction is extremely important in diabetes. So how many will go for therapy wise? What will be your third line here after metformin and SGLT2? If everything is available for you with deranged liver function, what is the safest choice here? Pardon? One person, I think if you are loud enough, it's... I don't know the evidence for it. You know, I know it's used in here. I have no idea about the evidence. Low dose pioglitazone is an option. I'll show it to you. Remember, we are talking about evidence-based medicine. Evidence which is, you know, looked at in a proper way. And my request to you here, whenever you are analyzing a paper, keep the pharmaceutical bias away. Please don't be taught by the, you know, billion-dollar industry. I'm son of a doctor, and in 1995, my dad, when I mentioned a trade name, said, "Do not use trade name, use pharmaceutical names rather than the trade names. Trade names change." Your development of concepts develops on your ability to understand the mechanism of a medication. You will be sold multiple medications, but you need to learn how to appraise the evidence. I don't know about the Salazar you are mentioning. You need to look at what kind of RCTs they showed benefit, and go through that paper in a deep detail, right? This is something which, if I had time, I would have gone with, I would have asked the organizers to keep critical review of the evidence as a total different kind of topic. So anyways, coming back to the clinical scenario, we need to assess the diabetes complications, assess CVD risk for heart failure just based on history, risk of hypoglycemia also in history. Then we do the examination to uncover any retinopathy, neuropathy. And then we do the biochemical investigation to look for derangement of liver and renal function, assess glycemic control. So, we are clinicians, we need to do things in a systematic manner and make it a habit to do it. Make it part of our existence to go by history, examination, and then investigation to support it. So anyone with diabetes, if you've taken history, done the examination and made a plan, you'll uncover what is the priority you need to focus on. So this is a diagnostic algorithm for prevention of cirrhosis in patients with metabolic dysfunction associated liver disease. One easy thing you can do in clinical practice is do the FIB4 scoring. If you know the ALT and AST and know the platelet count, in this slide I've mentioned how to calculate FIB4 score. If it is higher than 1.3 or equivalent, you can think about doing a fibroscan. Fibroscan will give you an idea about the liver stiffness, and then you can make a formulate a plan. As a physician, if patients have fibrosis, cirrhosis, you need to refer to the specialist rather than trying to do it on your own, everything, right? Now, metabolic dysfunction associated steatotic liver disease, the treatment algorithm, there are 3 aspects to it. Weight loss remains the key. How you achieve it is based on the resources available. Diabetes pharmacotherapy, most of the guidelines will mention about if it's F0 and F1, which is no or mild fibrosis, going for metformin, SGLT2 and GLP if patients can afford it. MASH specific pharmacotherapy, which as an endocrinologist excites me, is for F2 and F3 group. Unfortunately, this is still not available in EU at the moment or UK. But the FDA, Americans have approved this medication which acts on thyroid hormone receptor, which is beta selective, increases free fatty acid oxidation. I've mentioned the name in here. I've not used it. And again, this needs to be done or carried out under experts' supervision. So moving on to the clinical scenarios, I've got 12 more minutes. We started our journey with a pre-diabetes. We covered somebody with new diagnosis of diabetes. We mentioned about diabetes and liver disease. Now, people age, unfortunately. It's an irreversible process. I wish I could stay 16 at heart, which I am, but when I look at mirror, it's totally different. 78-year-old with established cardiovascular disease comes to you in the clinic on multiple polypharmacy. Some of the time it gets difficult to know which of these cocktails is doing benefit and which is doing harm. Has lost considerable amount of weight since diabetes was diagnosed. BMI is only 23.5, still carrying some adipose tissue around. So I'll share the results with you here. Element of anemia and renal impairment, HbA1c of 58, liver function is normal but has diabetic nephropathy. So my question to you now, right? And you need to write it down because I'm not giving any answers at the moment. I'll spend time over the coffee or over a cup of coffee or tomorrow's clinical scenario session. How do you manage diabetes in people who are getting old and frail? What should be your HbA1c target in this individual? How many will be happy with, let's say, 7% or 8%? Brilliant. Safety of medication and renal impairment. He was on metformin, he was on SGLT2 inhibitors, he was on statin therapy, he was on ACE inhibitor. How many will stop metformin? I'll remind you, eGFR was 37 or 38, if you've forgotten. How many will stop metformin? You do not stop metformin till eGFR is under 30. And the evidence for, non-safety of metformin is more historical based on fenformin data, not metformin data. So a gradual decline in eGFR, I don't stop metformin, even at eGFR of 25. Steep decline, steep organ failure, acute organ failure, you stop it. Lactic acidosis with metformin was not seen in UKPDS. So yes, the guidelines will say eGFR of under 30, stop it. But if it's a gradual decline, you can think about continuing it, right? Not under 20, but definitely 25 to 30 group, I don't stop it. SGLT2, should we stop it? I think pharma driven, lots of lectures, we know if eGFR is over 20 odd, we need to continue with it. Even in non-diabetes patients, we drive benefit. It's not the glycemic benefit, it's with progression of diabetic nephropathy. So when I started, teaching about SGLT2s, I remember saying, do not use it if eGFR, do not initiate if eGFR was under 60. Things have changed. So the non-glycemic benefit stay for SGLT2s till as long as the eGFR is over 20 ml per minute per 1.73 meters square, right? And impact of polypharmacy. We published a paper back in 2020. That was the only positive thing I did during the COVID time, apart from catching it and ending up with severe lung disease. Anyways, your glycemic control or glycemic goals do change with life. When you're younger, you're fitter, you're healthy, and definition of health is different. When you've got poorly controlled diabetes, you are adding 10 years to your biological life, vascular aging, right? So stringent controls, if somebody is fit enough, frail elderly, be a bit more relaxed. In addition, older adults with limited time frame, let them be happy without letting them go into hyperglycemic, osmolar syndrome. Let them be happy if you think mortality is an issue. Don't chase the numbers, treat the patient. Very complex slide in here. I'm not going to go into the details here because it's part of ESD and ADA criteria. You would have seen it often. Heart failure, nephropathy, SGLT2s have emerged as almost first line. I'm not counting metformin here. GLP-1s, if available, or incretin therapy, if patients can afford it, especially in the context of CVD, makes a difference. You need to consider insulin if you think patients are insulinopenic, right? So I'm not going to talk about this slide. It's available online and you can go through it. It's ADA recommendation and ESD endorsed. Lastly, you need to think about holistic patient-centric approach. I'll again reinforce, there is no point in acquiring knowledge if you can't apply it to the patient around. Treatment needs to be individualized. So my take-home message to you, I just wanted to go through some clinical scenarios. think about diabetes. I'm talking more on type 2 rather than type 1 terms here. It's a lifelong disease. It's not static. When you start the journey and when you end it, it's different. So you need, as clinician, to adapt to it. Always focus on the comorbidities and make sure through your history taking, through your examination, through your investigation, you are focusing on these and then prioritize what is important to you. Therapy needs to be individualized, and you need to have a proactive management early in life because you may need to use disease modifying medication or lifestyle interventions. And as we age in life, we need to simplify the regime. 80-year-old, my mom is 80 at the moment, she can't remember which medication she's taken, which she's not, and many of the time she repeats the same medication. Make sure the elderly, the frail you see in the clinic, medication regime is something which they can understand. Prioritize on the ones which are safe. As a physician, the only thing I've learned is the lesser medication I've used, better I am. And try to apply the self principle to the patient. Will you like this to be done to your own self? It's easy to give a cocktail of medication and then not knowing what the concussion does within the system. But if you keep it simple, results are much easier to interpret. So I've got less than 5 minutes and I've got 5 MCQs. Let me see how many of you were awake. The organizers are not here. If people get all right, they should have been given a hamper of chocolates or something. But chocolates would have increased your blood glucose. I don't prefer it. Question 1. Let's see how many were paying attention. Out of the 3 pillars, apart from diet and increased level of physical activity, what is the 3rd pillar for pre-diabetes? Sleep, 6 to 8 hours. So get away from your screens, the social media, and then try to sleep for 6 to 8 hours if you can. Second question, that was an easy one. So a 30-year-old comes into your clinic. He's been diagnosed to have diabetes around 18 months ago. BMI is 38 kg per meter, quite healthy. Yeah. And these are the results. My question to you is, what will be your preferred therapeutic option here? Brilliant. If affordable, I think the only one available in India at the moment is Ribelsis. The results are modest at the moment for Ribelsis. It's less effective than the injectable. I think the dual incretins and others are far more potency-wise impressive. 3rd question. So all fine so far, right? Everybody's getting correct answers. Mid-50s guy on a metformin and a DPP-4, ACE inhibitor and statin. And this is my go-to thing. If you are on a metformin, a statin, ACE or ARB, you have done your job. The rest of the things are bonus. BMI of 30.1. Deranged liver function, raised LDL, FIB-4 score of 1.3. This is slightly more complex, right? So my question to you, how many will go for A? Pardon? E, is it? B, start SGLT2. Happy, or is there any consensus here? I'll show you the scenario again. I can't go back. So FIB score was 1.3, borderline. I would have optimized the therapy using SGLT2, right? Or pioglitazone at a low dose. I don't use more than 15 milligram, right? 4th question. I've got only 2 left and I've got 2 minutes, right? 70-year-old on a whole cocktail of medication, ACE, DPP-4, metformin, aspirin, aldosterone antagonist, non-steroidal, and a statin, TIA and osteopenia. These are the blood test results. So this patient has diabetic nephropathy, and which of the following is the most appropriate in her case considering development of chronic kidney disease? Are you anyone else? Stop Finrenan? Yeah, you can continue with it as long as the EGFR is 25 to my knowledge. Stop linagliptin? No. Stop metformin? No, because you need EGFR to be over 30 as we discussed. Initiate SGLT2. As long as the EGFR is more than 20, it will have nephropathy protection effect. Last MCQ, 42 seconds. 62, not long to go for my retirement age, right? So, on metformin, SGLT2, bempedoic acid, complaining of increased thirst, nocturia, osmotic symptoms, BMI of 26.5, HbA1c of 88, right? Happy with the scenario? I want a loud answer so that I know you are awake. Well done. He's insulinopenic and you need to initiate insulin therapy here. So, thank you. Any questions? I've not given answers here. We'll have time for answering some of the things which I had asked you later on. I'll pass on to my next speaker. Thank you.